Thank you, Ajay. I shall be talking about the role of lasers and steroids in the management of diabetic macular edema. Two things which we are very clear about from our previous talks. One, we need a multifactorial approach. Second, most of the studies would combine lasers. So whether we like it or not, we are doing laser. And in the country where we have issues with the infection of anti-VEGF, where we have the issues of the spurious anti-VEGF drugs, we still can't escape the laser because monotherapy is really not the answer. So let's try to improve on the lasers then, because they remain the safest bet so far in a country like ours. A big question, why do we not like thermal lasers? Because whatever studies we have seen, which have been reported, have generally shown that following the laser monotherapy, the response, especially the visual improvement, is not very good. However, as mentioned by Dr. Atul, these studies were mainly concentrating onto the posterior pole and they have not really looked at the periphery, because one thing which is very clear is that VEGF is very important in causing diabetic macular edema. And that VEGF is coming from somewhere. It's not coming from the macula. So where is it coming from? It's coming from the periphery. With the availability of now the wide angle imaging, we are able to see the periphery far more clearly. And if we are charting out this periphery, we do realize there is a whole lot of area which is producing VEGF, which we are ignoring in patients with non-proliferative diabetic retinopathy, because we are not lasering it at all. For example, this is a patient which looks some macular edema, but when you do the wide angle angiography, you realize the extent of the ischemia which needs to be taken care of. So one of the options is to combine, for the better results, is do the targeted laser photocoagulation to the area which is in the periphery besides doing the conventional Fokker or grid laser. The second reason why we hate lasers is because sometimes, especially when we are young and we are beginning to learn, we do end up burning the foveas. So how could we do that? This is one example here. This is the patient who has undergone laser photocoagulation, and we can see this is something which is kind of criminal because the fovea has been burnt. And this is the adaptive optic OCT of the same patient, which is showing total loss of photoreceptor. This is how it should look like, a normal mosaic of cones, but this is what laser has produced. So how can it be avoided? This can be avoided by using a newer laser which is Navilas, that I don't have the time to go into the details, but with Navilas, for example, this patient, you can put a protector. So area where you don't want your laser burn to hit, you just put a marker out there. For example, this yellow circle in the center, this is the area which would be protected. Then you mark the area which you want to laser. For example, here we have marked the microaneurysms, or you can mark the grid. If you want to do you can mark the area of the leakage, and then you can look at these burns which you can apply in the grid fashion. So whatever area you want to protect, for example, you want to protect your optic disc, you can protect it by putting the marker there. And this is the result of the patient post-laser Navilas. So it does have an advantage of giving a clear-cut guidance, clear-cut plan, protecting the vital structures, doing the eye tracking while doing the laser with digital documentation and consistent application, taking a lot of human error away from the application of laser photocoagulation. And the third reason, even if we don't burn the fovea, we do have a very well-placed laser burns which are very good, but subsequently down the line, these laser scars enlarge, they undergo fibrosis, they cause the extension and compromise the vision. So what is the reason for that? The reason is very simple, that the lasers which we apply are the millisecond laser. So these millisecond lasers, when they cause the photocoagulation, they are associated with the primary damage both to the pigment epithelium as well as to the photoreceptor. So logically we should reduce the amount of the duration by which we are applying the photocoagulation. So there are microseconds laser, which is micropulse laser, where instead of applying the photocoagulation for milliseconds, we are just doing it for microseconds. Just enough not to kill, but just enough to take care of the energy which is required. MLT is really good, and there are a lot of reports on the use of MLT in the laser, but still MLT has an advantage that it is affecting the RPE. So we are now moving from micro to nanosecond pulse laser, which is not going to actually do any coagulation. It is just going to kind of tease the retina and the RPE enough to pump the fluid out of the retina which has been pooled, and this is being as 2RT, which is the photo rejuvenation therapy. So these are some of the advances which we are currently having in our laser photocoagulation to improve the performance. And this is just to show that if we apply the nanosecond laser, the collateral damage is minimized. Now the second part of the talk about the role of steroids in the macular edema. We did hear about from our previous speakers that steroids still have a role in some situations. So what are those situations? The first situation is that you have a huge subfoveal retinal detachment, as in this patient you can see the macular edema, which has a large component of a subfoveal detachment besides the cystoid spaces and the macular edema. So this is the patient, these are the kind of the patients where you want a prompt action, because anti-VEGF would work, but maybe after 6 or 7 injections. And if you want an early rehabilitation, steroids definitely work faster, and this is at 2 months. You can see the reduction of the edema. This is following Ozurdex implant. Secondly, many times we do see patients with macular edema which has not responded to anti-VEGF and to laser photocoagulation. This is still a category of patient. For example, this patient has received multiple anti-VEGF and laser but has not responded and responds to some extent to corticosteroids. We can see before and after injection of Ozurdex with visual improvement. The third category is the panel on the top shows a patient who required vitreous surgery. The bottom panel shows that after vitreous surgery, the traction is removed. There is no peripapillary traction or no foveal traction, but still the macular edema is persistent. So such kind of macular edema also would respond to corticosteroid injection or implant. This is the same patient before injection, and this is 3 weeks following Ozurdex implant. The fourth situation is, which is not standardized yet, but we are registered and we are working on it, is that many patients for vitreomacular traction, when we are doing surgery, if we want a very early visual rehabilitation, we can inject Ozurdex at the end of the surgery. To give you an example, this is a patient. He has a clear-cut VMT, undergoes surgery, and this is 3 months post-op. He still has the fluid and the cystic spaces, though we have removed the traction. On the other hand, this is the patient who undergoes surgery along with the Ozurdex implant, and this is 2 weeks post-op because we have removed the traction and the steroids take care of the rest of the residual edema. And my last indication for this would be before cataract surgery. We all understand that cataract, whenever we do in diabetics, is not a good experience because of the progression of macular edema and retinopathy, which occurs within the first 6 weeks because not of VEGF, because of the other mediators of inflammation. So logically, if you need to target it for the first 6 weeks, an implant is a good choice. So this is the patient before surgery. He received intravitreal Ozurdex along with phacoemulsification and IOL. This is post-op day 7. So visual rehabilitation is faster, and there is, we have reported it in ophthalmology that the progression of diabetic retinopathy can really be taken care of. So to conclude, in nutshell, treatment of the peripheral retina for macular edema, Navinas targeted laser treatment. If we are scared of the foveal burn or something, retinal rejuvenation therapy with the nanosecond laser is something we are looking forward to. And in certain select situations, steroids do have a role. Thank you very much.